Assalamu alaikum. My name is Muhammad Awais and I am an assistant professor in pediatrics department of the Said Medical College. Our today's topic is cystic fibrosis. It is the commonest life-limiting autosomal recessive condition in Caucasian with an incidence of 1 in 2500 live births and carrier rate of 1 in 25. It is well recognized but less common in other ethnic groups. However, definitely you can find few cases in our country, Pakistan as well. Average life expectancy has increased from few years to the mid-30s, with a projected life expectancy for current newborns into the 40s. The statement is regarding the developed countries like Western countries, UK, and other countries. So, the fundamental problem in cystic fibrosis is a defective protein called the cystic fibrosis transmembrane conductance regulator (CFTR). And CFTR is a cyclic AMP-dependent chloride channel found in the membrane of cells. The gene for CFTR is located on chromosome 7. Over 1,000 different gene mutations have been discovered that cause a number of distinct defects in CFTR, but by far the most frequent mutation in the UK is delta F508. So you can imagine varied kind of presentation due to these 100 different kinds of mutations in cystic fibrosis patients. Identification of gene mutation involved within a family allows prenatal diagnosis, means the diagnosis before birth, and carrier detection in the wider family like in parents. What is the pathophysiology? Cystic fibrosis is a multi-system disorder which results mainly from abnormal ion transport across epithelial cells. In the airways, this leads to reduction in airway surface liquid layer and consequent impaired ciliary function and retention of mucopurulent secretions. Chronic endobronchial infection with specific organisms such as Pseudomonas aeruginosa ensues due to the retention of these secretions. Defective CFTR also causes dysregulation of inflammation and defense against infection. And in the intestine, thick viscid meconium is produced, leading to meconium ileus in 10 to 20% of newborn infants. Likewise, in the pancreatic ducts, they also become blocked by thick secretions, leading to pancreatic enzyme deficiency and malabsorption. Abnormal function of the sweat glands results in excessive concentrations of sodium and chloride in the sweat. What are the clinical features? In the UK, screening of newborns is performed as part of the heel prick blood spot biochemical screen, Guthrie test, and also in other developed countries, these kind of screening tests are being done. So the majority of children with cystic fibrosis are identified by screening. However, children may still present clinically with recurrent chest infections, poor growth, or malabsorption. No such screening test is currently available in our country at the time of birth. No facility like this is available at the time of birth in our country. So if we categorize the clinical features in different age groups, so in newborn, it will be usually diagnosed through newborn screening. In infancy, meconium ileus in the newborn period. So the child would pass, the newborn would pass his or her first meconium more than 24 to 48 hours. So the mothers would come in the OPD and would complain that the baby has not passed any stool since 48 hours. or 2 to 3 days sometimes. Prolonged neonatal jaundice, more than 14 days, for example, more than 15 days. So the mothers would come in OPD and would complain of persisting jaundice for even after 14 or 15 days, and failure to thrive. These children would be uh, not thriving well because of the malabsorption, and there would be deficiency of macro and micronutrients. Recurrent chest infections is one of the presentation. Malabsorption and steatorrhea, foul, bulky, greasy stools. Young child presents with bronchiectasis, rectal prolapse, nasal polyp, or sinusitis. Older children and adolescent present like allergic bronchopulmonary aspergillosis (ABPA). Diabetes mellitus is one of the presentation. Cirrhosis and portal hypertension. Complication: distal intestinal obstruction. It's meconium ileus equivalent in adolescent. Pneumothorax or recurrent hemoptysis, and sterility in males. These are the complications in adolescent. Chronic infection with specific bacteria, initially Staphylococcus aureus and Haemophilus influenzae, and subsequently with Pseudomonas aeruginosa or Burkholderia species, results from viscid mucus in the smaller airways of the lungs. This leads to damage of bronchial wall, bronchiectasis, and abscess formation. So, chest X-ray of one of the patients with cystic fibrosis showing haziness in the lung areas bilaterally due to some ongoing infection. The child has persistent loose cough productive of purulent sputum. On examination, there would be hyperinflation of the chest due to air trapping, so the chest will be deformed. The coarse inspiratory crepitations and or expiratory wheezes could be heard in the chest examination. With established disease, there is finger clubbing. Ultimately, 95% die of respiratory failure. Over 90% of children with cystic fibrosis have pancreatic exocrine insufficiency, lipase, amylase, and proteases, resulting in maldigestion and malabsorption. Untreated, this leads to failure to thrive and passing, frequent large, pale, very offensive, and greasy stools, which is steatorrhea. Pancreatic insufficiency can be diagnosed by demonstrating low elastase in faces. About 10 to 20% of cystic fibrosis infants present in the neonatal period with meconium ileus, in which inspissated meconium causes intestinal obstruction, vomiting, abdominal distension, and failure to pass meconium in the first few days of life. Initial treatment is with gastrografin enemas, but most cases require surgery. How we diagnose? Besides clinical parameters, the essential diagnostic procedure is the sweat test to confirm that the concentration of chloride in sweat is markedly elevated. So chloride would be between 60 to 125 in cystic fibrosis as compared to 10 to 40 millimole per liter in normal children. Sweating is stimulated by pilocarpine ionotophorosis, and confirmation of diagnosis can be made with testing of gene abnormalities in the CFTR protein. If a child is homozygote with 2 identified mutations, then they have cystic fibrosis. So management. The effective management of cystic fibrosis requires a multidisciplinary team approach including pediatricians, physiotherapists, dietitians, specialist nurses, a primary care team, teachers, and most importantly, the child and parents. All patients with cystic fibrosis should be reviewed at least annually in special center. The aims of therapy are to prevent progression of the lung disease and to maintain adequate nutrition and growth. Recurrent and persistent bacterial chest infection is the major problem. So in younger children, respiratory status is monitored on symptoms, and in older children that should be monitored by lung function regularly by spirometry. The FEV1, forced expiratory volume in 1 second expressed as percentage predicted for age, sex, and height, is an indicator of clinical severity and declines with disease progression. With regular treatment, most infants and children with cystic fibrosis should have no respiratory symptoms and often have no abnormal signs. From diagnosis, children should have physiotherapy at least twice a day, aiming to clear the airways of secretions. So, chest physiotherapy especially. Many cystic fibrosis specialists recommend continuous prophylactic oral antibiotics, usually flucloxacillin, with additional rescue oral antibiotics for an increase in respiratory symptoms or decline in lung function. Persisting symptoms or signs require prompt and vigorous intravenous therapy to limit lung damage. Usually, they are administered for 14 days via peripheral venous long line. Chronic Pseudomonas infection is associated with a more rapid decline in lung function, and this is slowed by the use of daily nebulized anti-pseudomonal antibiotics. Nebulized DNase or hypertonic saline may be helpful to decrease the viscosity of the sputum and so increase its clearance. The macrolide antibiotic like azithromycin given regularly decreases respiratory exacerbations, probably due to an immunomodulatory effect rather than antibiotic action. Regular nebulized hypertonic saline may decrease the number of respiratory exacerbations. So bilateral sequential lung transplantation is the only therapeutic option for end-stage cystic fibrosis lung disease, but fortunately this is rarely required. Nutritional management, the dietary status should be assessed regularly. Pancreatic insufficiency treated with oral enteric-coated pancreatic replacement therapy taken with all meals and snacks. Dosage is adjusted according to clinical response. A high-calorie diet is essential and dietary intake is recommended at 150% of normal RDA. To achieve this, overnight feeding via a gastrostomy is increasingly used. Most patients require fat-soluble vitamin supplements. As these things have already been discussed, so in adolescents, in adults and teenagers, complications like diabetes mellitus and chronic liver disease are common. Other complications are like distal intestinal obstruction syndrome and recurrent infection, especially with Pseudomonas and Burkholderia species. Females have normal fertility, and unless they have severe lung disease, tolerate pregnancy well. Males are virtually always infertile due to absence of vas deferens, although they can father children through intracytoplasmic sperm injection (ICSI). The psychological counseling for patients and for parents as a family is very much important. Screening. All newborn infants born in the UK are screened for cystic fibrosis. Early identification of cystic fibrosis allows the early introduction of regular treatment. It also enables early genetic counseling for the parents about the 1 in 4 risk of recurrence and the possibility of prenatal diagnosis, the diagnosis before birth in future pregnancy. Thank you very much. Thanks.